Have you ever found yourself caught in that familiar healthcare tangle? The endless paper forms, the long waits, or just that nagging feeling that your medical history is scattered across different systems, impossible to access when you really need it?
Oh, absolutely. I think most people have felt that frustration at some point.
You're certainly not alone. Today, we're taking a deep dive into healthcare information and systems management
Hmm.
to uncover how technology isn't just a minor upgrade, but a seismic shift in how care is delivered.
Mm.
It's a shortcut, really, to being truly well informed on this vital transformation.
It's a global reality. Healthcare systems worldwide are grappling with dynamic changes. And what's truly fascinating is how information technology, or IT, holds the key to unlocking better care and greater efficiency.
Right.
Yet, surprisingly, it's been a tough uphill climb for adoption in many places. There are some significant hurdles.
So, our mission today is to peel back the layers and understand why IT adoption in healthcare has lagged so notably behind other industries. We hear about tech everywhere else, but healthcare seems different.
It does, yeah.
We'll then explore the immense opportunities it presents for both patients and providers. And finally, look at the surprisingly rigorous step-by-step processes involved in actually bringing these vital technological changes to life. We're distilling all of this directly from our source material so you get the full picture.
From the ground up.
Exactly. From the current challenges and the promised benefits to the systematic approach needed to bridge that glaring tech gap. Now, here's where it gets really interesting, I think. Despite all the innovation we see in every other sector, banking, retail, you name it, healthcare has been remarkably slow to embrace IT.
It's quite striking when you compare them.
It is. Our sources reveal a stark picture. Back in 2018, only a meager 4.26% of healthcare revenues were spent on technology, just over 4%.
That's incredibly low for such a data-intensive field.
Right. And while predictions for early 2019 hinted at an increase, maybe getting closer to 9%, the vast majority of that money was still being sunk into maintaining existing, often outdated infrastructure.
Yeah, keeping the lights on, basically.
Exactly, not into genuine transformative growth. It's like pouring money into patching up an old car instead of buying a new, more efficient model that could actually, get you further faster.
That's a great analogy. And that limited investment isn't just about a lack of funds, though that's part of it sometimes. It points to deeper systemic challenges unique to healthcare.
Okay, like what kind of challenges?
Well, think about it. This is an industry steeped in complex regulations, fee-pay in the US, GDPR in Europe, and similar rules elsewhere. Change is inherently risky,
Sure, patient data is incredibly sensitive.
extremely. So there's a high degree of risk aversion, naturally. Then you have a very fragmented market. Lots of different providers, hospitals, clinics, payers, not always working in concert. Funding models can be rigid, often fee-for-service, which doesn't always incentivize investment in efficiency tech.
Right, if you get paid per procedure, maybe making things too efficient isn't the top financial priority for some.
That can be a factor, unfortunately. And frankly, there can be significant clinician resistance. Doctors and nurses are already overworked. If new technology feels like it's adding clicks, disrupting workflow, or taking time away from patients, even with good intentions,
They're going to push back.
they might, yeah. Unless the benefits are immediate and obvious and the implementation is done really well with good training and support.
So it's not just a budget issue, it's cultural, it's structural, it's regulatory, it's complicated.
Precisely. And that reluctance, that slow pace, has perpetuated some core problems within the traditional way of doing things. We're talking about, first off, poor data quality.
How so?
Information is often redundant, entered multiple times in different places, maybe slightly differently each time, or it's collected using inconsistent standards. One clinic asks for your weight in pounds, another in kilograms, or they use different codes for the same diagnosis.
Which makes comparing or analyzing that data really difficult.
Exactly. Then there's the sheer inaccessibility of information. Trying to get your health data when and where you need it, maybe you're traveling or seeing a new specialist, it's often a frustrating manual process. Fax machines are still surprisingly common.
More fax machines. In 2024, it's hard to believe.
It is. And many critical patient records, believe it or not, still exist only on paper in some places. Logbooks, older charts, completely hindering quick access, especially during an emergency. Imagine paramedics needing a patient's allergy info now, and it's locked in a filing cabinet somewhere.
It's like trying to find a needle in a haystack of physical files when every second counts. That's terrifying.
It really is.
Yeah.
And even when digital systems do exist, there's this pervasive lack of interoperability. That's the key word.
Meaning they don't talk to each other.
Exactly. The hospital system doesn't communicate with your GP system, which doesn't talk to the pharmacy system or the labs.
Hmm.
So data accuracy, integrity, and completeness are constantly compromised. Information gets lost or duplicated, or it's just not available where it's needed most.
So you end up repeating tests, or the doctor doesn't have the full picture.
Precisely. And historically, if you look back, most of these early systems were built to serve administrative functions. Billing, scheduling, inventory maybe,
Right. The back
the
office.
back office, not the direct needs of doctors, nurses, or critically patients themselves. So many traditional setups are just missing vital functions we now sort of expect or should expect.
Like what's missing?
Things like computerized practitioner order entry, or
Mhm.
CPOE. That's where doctors enter medication orders, lab requests, imaging orders directly into the system, not on paper.
Reduces handwriting errors, I imagine.
Hugely. Illegible handwriting on prescriptions is a classic source of errors. Also missing, truly integrated electronic health records, or EHRs, that provide a complete longitudinal view of the patient. Proper digital image archiving past CS systems so X-rays and scans are easily accessible. Essential prescription error alert systems that automatically check for dangerous interactions or allergies. And even basic electronic monitoring for high-care patients, feeding vital signs directly into the record. It's a complex web of disconnected, often outdated parts.
Wow. Okay, so that paints a pretty clear picture of the challenges. Let's shift gears then. When we talk about integrated information systems, often called hospital information systems, HIS, or just healthcare information systems, we're not just talking about minor tweaks anymore. We're talking about comprehensive solutions designed to tackle these deep-seated problems head on. What's the real potential here for you, listening at home as a patient, or even for the clinicians?
The potential is genuinely transformative. It's about moving from that fragmented, reactive state to something much more cohesive and proactive. These advanced systems offer multifaceted benefits across the entire healthcare ecosystem, directly addressing those pain points we just discussed.
Okay, break that down for us. What kind of benefits are we talking about?
Well, let's start with the operational benefits. Imagine a hospital where staff productivity soars because they spend significantly less time chasing paper, deciphering notes, or re-entering data.
More time for patient care.
Exactly. That's the goal. Costs are reduced, less paper, fewer redundant tests, more efficient workflows. Data quality dramatically improves because information is entered in standardized ways, ideally just once, and sharing that patient information becomes seamless and secure between authorized providers. All of this leads directly to a significant reduction in medical errors. Remember those inconsistent paper records, the fax machines? This fixes that.
That's a huge shift right there, moving from a system where errors happen despite best efforts to one that actively prevents them.
Absolutely, that's a core promise. Then there are the managerial benefits. For hospital administrators, leaders gain unprecedented control and understanding of their clinical and operational processes. They can see bottlenecks, track outcomes, monitor resource use in real time.
Better data for better decisions.
Precisely. Which enables far better decision-making, more effective resource allocation, getting staff and equipment where they're needed most. And this directly translates into higher quality of care metrics and improved overall performance, both clinical and financial.
Okay, operational, managerial. What else?
Strategically, these systems are game changers. They enable more effective long-term planning based on real population health data. They enhance collaboration, not just among doctors and nurses, but with pharmacists, therapists, labs, even patients themselves through portals.
Right, involving the patient more.
Yes. And it can foster better relationships with suppliers through more efficient inventory and ordering. Ultimately, the strategic goal is improved population health outcomes, identifying trends, managing chronic diseases better across large groups. And for individuals, it quite literally can mean increased survival rates and a better quality of life, because care is more timely, coordinated, and evidence-based.
That's the ultimate goal, isn't it? Better health.
It is, and we shouldn't forget the IT infrastructure benefits themselves. Using modern integrated systems promotes reusability of components, reducing the cost and risk of developing future applications. And crucially, it provides the backbone needed to support the growth of e-healthcare and telemedicine, which we saw explode during the pandemic.
Yeah, telemedicine really took off.
And it needs robust systems behind it. Finally, there are the organizational benefits, which often overlap but are worth highlighting. We're talking reduced needs for hospitalization in some cases, or shorter lengths of stay when admission is necessary, dramatically cut waiting times for appointments or results, fewer canceled operations due to better scheduling and resource management.
Things that directly impact the patient experience.
Directly. Think about it. Increased business efficiency for the hospital, yes, but also reliable data for clinical research and analysis, a massive reduction in frustrating paperwork for everyone, and just more effective clinical and administrative management overall. It's potentially a win on every single front.
Okay, that's a compelling list of benefits. To make this even more concrete, let's talk about some specific IT applications you might encounter or hope to encounter soon. Take electronic health records, or EHRs.
Right, the EHR is often seen as the cornerstone.
These are designed to standardize how your patient information, your history, diagnoses, medications, allergies, lab results is entered, stored, and retrieved, ideally across different healthcare organizations.
That across organizations part is key and often the trickiest.
Exactly. The biggest hurdle, historically, as you mentioned, has been establishing a universal industry standard, or at least effective ways for different systems to exchange data meaningfully, so that your records at Hospital A can seamlessly and securely talk to your specialist at Clinic B, or the ER doctor if you're admitted while traveling, all while ensuring rock-solid security against unauthorized access.
That interoperability piece is absolutely fundamental to realizing the full potential of EHRs. Without it, you still have digital silos, which is better than paper silos, but still not ideal.
Okay, so EHRs are the foundation. What about that CPOE you mentioned earlier, computerized practitioner order entry?
Yes, CPOE. This directly replaces the traditional handwritten prescription pad or order form. Imagine a doctor typing a medication order directly into a secure system. Instantly, the system can check that order against the patient's known allergies stored in the EHR. It can flag potential drug interactions with other medications the patient is already taking. It can check for incorrect dosages based on the patient's age or weight or kidney function. It can suggest alternatives if needed.
So it's like having a safety net built right into the ordering process.
A very powerful safety net. It essentially eliminates the risks of illegible handwriting, transcription errors, and many common types of medication mistakes. Plus, it speeds up care significantly. The order goes electronically to the pharmacy or the lab immediately.
And this ties back to that statistic you mentioned.
It does. When you consider that medication errors alone, and this is based on a 2016 report, so the numbers might even be higher now, account for more than 3.5 million physician office visits and 1 million emergency department visits each year in the U.S.,
Wow.
costing almost $21 billion annually. CPOE, when implemented well alongside an EHR, can drastically reduce those numbers. It's a massive patient safety and cost-saving tool.
That statistic is just staggering. It really highlights the immense human and financial cost of not having these systems widely and effectively in place.
It absolutely does. It underscores the urgency. Then we have clinical decision support systems, or CDSS. These often work hand-in-hand with EHRs and CPOE.
Okay, what do they do?
They provide clinicians with knowledge and person-specific information, intelligently filtered or presented at appropriate times, to enhance health and healthcare. So, for example, based on a patient's data in the EHR, a CDSS might pop up an alert reminding the doctor about a needed vaccination, or suggest evidence-based diagnostic possibilities, or provide guidelines and warning systems for particularly high-risk medications or procedures.
So it's not making the decision for the doctor, but supporting their decision-making process with relevant info.
Exactly. It's like having an expert consultant or the latest research embedded right into the workflow, offering timely advice, almost like a second set of digital eyes focused on best practices.
Got it. What about imaging? X-rays, MRIs?
That's where picture archiving and communication systems, or PACS, come in. These systems integrate various diagnostic imaging tools, X-ray, CT, MRI, ultrasound, storing the digital images and allowing them to be viewed electronically.
No more hunting down physical films.
Hopefully not. PACS makes it much easier and faster for your doctors, radiologists, specialists, even surgeons in the OR to access and review your scans instantly, securely from different locations. They can zoom in, compare images over time, collaborate more easily. It improves diagnostic speed and accuracy.
Okay. And you also mentioned RFID, radio frequency identification. How does that fit in?
Yeah, RFID and other real-time location systems, RTLS, or monitoring technologies are being used in interesting ways. RFID tags can be used to track expensive mobile equipment, making sure it's available when needed, or they can be integrated into patient wristbands.
To track patients, does that raise privacy concerns?
It can, and those need to be managed very carefully with clear policies. But the goal is often patient safety, ensuring the right patient gets the right medication or procedure, or locating a disoriented patient quickly within a facility. Other systems automatically collect and transmit vital signs, pulse, temperature, blood pressure, oxygen saturation, directly from the patient's bedside monitor into the EHR.
Ah, so reducing manual charting errors for nurses.
Exactly. Less time spent manually recording vitals, fewer transcription errors, and quicker alerts if a patient's condition starts to deteriorate. All of this can lead to shortened treatment times, greater cost efficiency through better staff allocation, and ultimately better resource utilization overall.
Makes sense. And finally, you mentioned systems for managing medications and supplies.
Right. Things like automated dispensing machines or ADMs, often found on hospital wards or in pharmacies. These are like secure vending machines for medications, helping control inventory, improve dispensing accuracy, and track usage.
So nurses aren't just grabbing things from an open shelf.
Ideally not for controlled substances, no. ADMs add a layer of security and accountability. And alongside that, you have electronic materials management, or EMM, systems. These function much like enterprise resource planning ERP systems you'd find in other industries, but tailored for healthcare. They manage the procurement, inventory, and usage of pharmaceuticals, medical supplies, surgical instruments, everything needed to run the clinical side, ensuring things don't expire on the shelf, managing recalls efficiently, optimizing stock levels.
So it's a whole suite of interconnected tools, ideally working together from the patient record to ordering, decision support, imaging, tracking, and even managing the physical supplies.
That's the vision, yes. A seamless, integrated ecosystem.
This all sounds incredible, truly transformative, but it also raises that important practical question. How do healthcare organizations, hospitals, clinics, health systems actually figure out exactly what they need to improve to achieve all these benefits? It's not like they can just wave a magic wand and install better care software. There must be a process.
Absolutely. You can't just buy technology off the shelf and expect it to magically fix underlying problems. In fact, automating a bad process just makes you do the wrong thing faster.
Right, garbage in, garbage out, amplified.
Precisely. So that's where needs analysis, often called gap analysis,
Well,
comes in. It's a foundational step. You have to start here.
okay, what does that involve?
Its purpose is to systematically identify the main challenges the organization is facing and specific needs that IT could potentially solve. Are the problems primarily operational long wait times, staff burnout? Are they administrative inefficient billing, poor scheduling? Or are they related to broader industry pressures, new regulations, need for better quality reporting?
So defining the problem first.
Clearly defining the problem, yes. Then, performing a crucial cost-benefit feasibility study. Is there a realistic financial and operational case for investing in a solution? Does the potential benefit outweigh the cost and disruption? And based on that, outlining a high-level framework for the kind of system or changes needed. It's about understanding the as-is state and defining the desired-to-be state.
What kind of needs typically surface during this analysis in healthcare?
Well, several key themes tend to emerge consistently. One big one is improving staff productivity and satisfaction.
We talked about clinician burnout.
Exactly. So needs related to reducing administrative burdens, eliminating redundant tasks, making information easier to find anything that allows nurses, doctors, and other staff to spend more time on direct patient care and less time fighting the system. This is also key for employee retention, which is a huge issue.
Makes sense. Happy staff, better care, lower turnover costs.
Definitely. Then there's the, perhaps more obvious, push for increased revenue and cost optimization. This could involve IT solutions that help boost outpatient visitor capacity, shorten inpatient lengths of stay safely, enable more efficient stock control to reduce waste, or lower the daily cost of treatment through better resource management,
The financial health of the organization.
which is essential for sustainability. But critically, perhaps the most powerful driving force for IT adoption, especially from a clinical perspective, is patient safety.
Right. Minimizing errors.
Minimizing errors in treatment administration and procedures, or particularly in prescriptions.
Yeah.
Reducing adverse drug events, or ADEs, is a major focus here. Any IT solution needs to demonstrate how it will make care safer.
Non-negotiable, really.
It should be.
Like-
And closely related is enhancing the overall quality of care. This is broader than just safety. It includes patient satisfaction through reduced delays, ensuring appropriate procedures are followed based on evidence, improving the perception of professionalism, and again, reducing length of stay where appropriate.
So the patient's experience and outcomes.
Exactly. And finally, A growing need is improving patient access to services, streamlining frustrating processes like getting lab reports back quickly, understanding bills, or booking appointments. Think about online portals, secure messaging, remote scheduling options, integrated links to labs so results flow directly to the patient and provider, making healthcare easier to navigate for the patient.
So staff needs, financial needs, safety, quality, access. It's a lot to juggle.
It is, and what's fascinating is to see how these priorities sometimes shift depending on who you ask. Our sources suggest that for an individual hospital or clinic, the hierarchy often goes patient safety first, absolutely paramount, then profitability, financial health, followed by ease of processes for their staff, and then, maybe further down, industry standardization.
Okay, that makes sense for a single entity trying to survive and thrive.
Right. But if you look at the healthcare industry as a whole, or from a regulator's perspective, the order subtly changes. Patient safety, and now, increasingly, data security are top. Then professionalism and adherence to standards. Then standardization across the industry becomes much more important to enable that data sharing and benchmarking we talked about. Profitability is still there, of course, but maybe slightly lower in the ranking than for an individual facility. And ease of processes might come last from that broader viewpoint.
Interesting. So the challenge for any specific IT project is to somehow strike that delicate balance, satisfying the immediate needs of the facility while also aligning with those broader industry goals like standardization.
That's exactly the tightrope they have to walk. Yeah. It requires careful planning and communication.
So how do organizations get a clear handle on those ease of process issues, the bottlenecks, the inefficiencies, before they try to fix them with tech?
That's where visualization becomes incredibly powerful. They use tools like workflow and process mapping.
Okay, what does that look like?
These are essentially visual aids, flow diagrams, swim lane charts, value stream maps that meticulously document how work currently gets done. Step by step, who does what, where information flows, where handoffs occur, how long each step takes.
Laying it all out.
Exactly. The purpose is twofold. First, to really understand the current processes in detail. And second, crucially, to identify broken, inefficient, or redundant steps before you even think about automating them. You want to improve the process first, then automate the improved process.
Fix the workflow, then add the tech.
Precisely. This mapping is also vital for change management, helping staff see why changes are needed and how the new system will actually help them.
Can you give us a tangible example of how that mapping might reveal an issue that IT could solve?
Certainly. Let's take the typical process for nurses briefing patients on their lab results, maybe routine blood work. Without good IT integration, the process map might show a nurse printing the result, trying to call the patient, leaving a voicemail, trying again later, maybe playing phone tag for days.
Wasting a lot of nurse time.
A huge amount of time, potentially delaying the patient getting important information, and limiting how many patients that nurse can effectively manage in a day. The process map would clearly highlight that calling loop as a major bottleneck.
And the IT solution?
With IT, specifically a secure patient portal or secure messaging integrated with the EHR, the map changes dramatically. The result comes in electronically, the doctor reviews and annotates it, and a notification goes out automatically via the portal or secure email. The patient logs in at their convenience, gets the info, maybe sends a quick clarifying question back. It transforms a frustrating, time-consuming chase into a convenient, efficient briefing.
Much better. Another example.
Let's consider the referral to specialist booking process. A patient sees their primary care doctor, gets a referral. The process map might show the referral being fax. There's that fax machine again. Then the specialist office calls the patient. Maybe days later, they try to align schedules, maybe need to get pre-authorization from insurance. It can stretch out. Our sources indicate a patient might wait up to 2 weeks just between getting that referral slip and actually having the appointment booked.
2 weeks of waiting and uncertainty, especially if you're worried about something. That's a long time.
It really is. And it's often just due to communication friction and administrative delays. The process map would show all those potential waiting points.
And how could IT help there?
IT can drastically reduce this. Electronic referral systems send the information instantly and securely. Online scheduling tools let patients see available slots and book directly. Secure messaging can handle quick questions. Even things like remote consultations via video conferencing for initial assessments or enabling secure digital signing for consent forms can shave days or weeks off the process.
So streamlining the whole pathway.
Exactly. And these improvements aren't just theoretical. They extend to other notoriously inefficient areas, like complex hospital billing systems, discharge planning, medication reconciliation, all benefit from mapping the current state and then applying computer-aided work management and communication tools.
So, as these workflows are laid bare by the mapping, opportunities for process improvement naturally emerge. And you mentioned these aren't just corporate buzzwords, they're structured, data-driven approaches.
That's right. Once you've identified the problems and mapped the process, you need a systematic way to make improvements. Methodologies like DMAAC, which stands for Define, Measure, Analyze, Improve, and Control, provide a rigorous, data-driven strategy often used in Six Sigma quality initiatives.
Define the problem, measure how bad it is, analyze why, improve it, and control it so it stays fixed.
That's the essence of it, yes. Very structured. Another common one is PDCA, sometimes called PDSA plan, do, check, study, and act. This is more of a cyclical approach for continuous improvement. You plan a change, you implement it, often on a small scale first, you check or study the results, and then you act, either adopting the change fully, modifying it, or abandoning it if it didn't work. Then you start the cycle again.
So it's about continuous learning and refinement.
Exactly. Both DMAIC and PDC-PDCA provide frameworks for making things genuinely better based on evidence and data, not just implementing change for change's sake.
Okay, so the needs are identified through gap analysis, the current processes are understood through mapping, and improvement methodologies are chosen. What's the next critical step before you actually, buy or build anything?
The next critical step is to define in detail exactly what the new system, the to-be state, will actually do. This is known as requirements analysis.
Getting specific.
Very specific. It's about creating a documented, unambiguous record of all the system's functions and characteristics. Think of it as the detailed blueprint for the new technology solution.
And why is this blueprint so important?
It's absolutely crucial for several reasons. First, it serves as the basis for designing and building or configuring the system. Second, it's essential for developing test cases. Later on, how will you know if the system actually works as intended if you haven't defined what intended means? Third, it's critical for accurately estimating the resources needed: time, money, people for the project. Without clear requirements, project scope creeps, budgets balloon, and timelines slip.
So it anchors the whole project. What kind of requirements are we talking about?
They're typically categorized. You have functional requirements. These describe what the system must do. For example, the system must allow clinicians to electronically prescribe medications, or the system must generate daily census reports.
The core features.
Exactly. Then you have reporting requirements, specific reports the system needs to produce. Regulatory requirements, functions needed to comply with laws like HIPAA or quality reporting mandates. Data requirements, defining the data elements needed, their formats, validation rules, and how data will be converted or migrated from old systems. Security requirements are obviously huge in healthcare, defining user roles, access controls, audit trails, encryption standards. Performance requirements, specifying how fast the system needs to respond, how many users it must support simultaneously, uptime guarantees. And critically, interoperability requirements, defining how this new system needs to exchange data with other existing systems, like the lab system or the billing system, using standards like HL7 or FHIR.
That seems incredibly detailed. It must take a lot of effort to get those right.
It does, and it requires input from all stakeholders: clinicians, administrators, IT staff, billing, registration, sometimes even patients. But skipping or rushing this step is a recipe for disaster later on.
Okay, so now you have this detailed blueprint of what you need. The requirements are crystal clear. But how do you pick the right solution from the dozens, maybe even hundreds, of technology vendors out there all claiming they can meet your needs? This must be where things like RFIs and RFPs come in.
Exactly. This is a formal process of vendor selection, and it's designed to be structured and fair. It usually starts with a request for information, or RFI.
RFI, what's its purpose?
An RFI is typically a less formal document. Its main goal is to gather general information about potential vendors and their products or services. It helps the organization understand the landscape of available solutions and narrow down a large pool of potential vendors, maybe from, say, 10 or 20 possibilities, down to a more manageable shortlist of maybe 4 or 5 serious contenders. It asks broader questions about company stability, experience, general product capabilities.
So casting a wide net initially, then filtering.
Precisely. Once that shortlist is established, the organization typically issues a request for proposal, or RFP.
RFP, this one sounds more serious.
It is. The RFP is a formal, detailed document sent only to the shortlisted vendors. It contains all those specific system requirements we just talked about, often in granular detail. It asks vendors to explain exactly how their specific product or service will meet each requirement. They also have to provide information on their implementation methodology, training plans, support services, and detailed pricing.
So they have to respond point by point to the blueprint.
Exactly. The real power of the RFP process is that every vendor receives the exact same document and has to answer the exacting questions in the same formats. This allows for a much more objective apples-to-apples comparison of the different offerings rather than just relying on slick sales demos. This process, if done well, eventually leads to selecting a vendor and negotiating a contract.
Makes sense for ensuring fairness and clarity. Are there other related requests?
Sometimes, particularly if pricing in the RFP responses is complex or unclear, an organization might issue a request for quotation, or RFQ. This is used purely to obtain specific detailed pricing information, often as a final step before negotiation. And critically, throughout this entire RFI, RFP, RFQ process, where the organization is sharing its needs and vendors might be sharing proprietary information, a non-disclosure agreement, or NDA, is absolutely essential.
To protect confidentiality on both sides.
Yes, it's a legal agreement ensuring that sensitive information shared during the evaluation process isn't disclosed inappropriately. Standard practice.
So it's a very formal courtship, really. Defining needs, scouting the field, detailed proposals, price checks, all under confidentiality, making sure everyone is on the same page before making what's usually a huge financial and operational commitment.
That's a good way to put it. It's a significant undertaking. And connecting all this meticulous information, gathering the needs analysis, the process mapping, the requirements of vendor proposals, it all feeds into one final critical step before the final decision is made. The cost-benefit analysis, or CBA.
Right, the bottom line. Does it make financial sense?
Essentially, yes.
Mm-hmm.
The CBA is a quantitative technique, meaning it tries to put numbers on things used to systematically evaluate the projected benefits of investing in a particular product or service against all of its anticipated costs.
And costs aren't just the sticker price of the software, right?
Not at all. That's a common mistake.
Mm-hmm.
The CBA has to account for all costs. The hardware, the software licenses, the implementation services, which can be significant, the cost of data migration, user training time, which means time away from patient care, ongoing maintenance fees, support contracts, potential infrastructure upgrades needed.
It adds up quickly.
It really does. And on the other side, you have the benefits. Some are tangible and easier to quantify, like reduced transcription costs, fewer redundant tests, faster billing cycles leading to improved cash flow, potentially increased patient volume due to efficiency. But others are intangible, yet incredibly important.
Like improved patient safety or staff morale. How do you put a number on that?
That's the challenge of a good CBA. You often have to use proxy measures or make reasoned estimations. For example, you might estimate the cost savings from avoiding a certain number of adverse drug events based on national data. Or you might link improved staff satisfaction, measured through surveys, to projected reductions in turnover costs, recruitment, training. It requires careful analysis and realistic assumptions.
So the goal is to show that the sum of the benefits, both tangible and intangible, outweighs the total cost over a specific time frame.
Exactly. Over the expected life of the system. And the intended achievements, drawing from that detailed comparative analysis of requirements and vendor proposals, are usually quite significant for everyone involved. We're talking about things like measurable reductions in patient queue times. Our sources suggest potentially cutting them by up to half in some areas.
Wow, half the weight.
Potentially. Instant retrieval of patient records when needed. Greatly reduced prescription errors, as we discussed with CPOE. And achieving enhanced industry standardization, which not only improves data sharing, but can lead to improved overall business operations and benchmarking.
And the financial outlook from a successful implementation.
Generally, it's overwhelmingly positive in the long run, even with the significant upfront investment. The anticipation is for a continuous reduction in operational costs over time, a net increment in revenue through efficiency and potentially enhanced services, and all while delivering vastly better service quality, improved safety, and higher satisfaction for you, the patient. It's an investment in the future health of the organization and the community it serves.
So we've taken a really comprehensive deep dive today into the complex yet incredibly promising world of healthcare IT. It's been quite a journey.
It covers a lot of ground, doesn't it?
It really does. From understanding why this crucial sector has, perhaps surprisingly, lagged for so long in tech adoption, to exploring the vast opportunities for vastly improved patient care, much greater efficiency, and even better financial health for the institutions we rely on. And then peeking behind the curtain at that meticulous, almost painstaking process involved identifying the real needs, mapping the current messy reality, defining precise requirements, and carefully selecting the right solutions through things like RFPs and cost-benefit analyses.
It's definitely not a simple plug-and-play situation.
Not at all. It's clear that the future of healthcare is undeniably intertwined with how effectively we embrace and implement these technological advancements. It's not really an if anymore, but a how and when.
Indeed. And I think it's important to reiterate that this transformation isn't just about plugging in new software or buying more hardware. That's just the tool. It's really about fundamentally rethinking how healthcare is delivered. It's about changing processes, changing workflows, changing culture, all with the aim of making care safer, far more accessible, more coordinated, and ultimately more personalized for every individual. The overarching goal has to be ensuring that this wealth of information and technological capability is truly understood and applied for the greatest possible impact on health.
A powerful summary. So, for you, our listener, reflecting on everything we've discussed today, here's something to consider. Given the immense potential for IT to revolutionize healthcare to make it safer, more efficient, more patient-centered, what do you believe is the single biggest barrier holding back its full adoption in your own community or country? Is it cost? Is it regulation? Is it resistance to change? Something else. And perhaps more importantly, what's one small step you think could begin to address that barrier?
That's a great question to ponder.
Something to think about. Join us next time on The Deep Dive for another journey into being truly well-informed.